Hi, everyone. I'm Lauren Zajac, and Maida and I are going to be switching places a few times to keep things interesting. So, thank you to Veronica and to Jerry Paulson for inviting us. We are absolutely thrilled to be here and be part of this very important conversation. So today, Maida and I will be discussing the principles of children's environmental health from a clinical perspective, with a focus on promoting environmental health in the school environment. And the way we're going to structure our talk is first I'm going to give a basic overview of children's environmental health and how it relates to the school environment. And then Maida is going to discuss several of our large school-based PESHU cases that we've worked on in the past few years. And then I'm going to wrap up by just describing some key resources that we found useful at our PESHU. But then I really hope to leave ample time at the end to continue the great discussion that already started with the last speaker. We would love to hear from you guys, hear your experience, learn from you, share ideas, share resources. So we'll go through the first few points quickly. If at any time you have a question, please just let us know. So as Jerry discussed, we're from another PESHU, the Region 2 PESHU. And basically, just to review, or in case you weren't here early this morning, we're a network, a national network of environmental health centers, and we provide clinical consults on environmental health cases, and we do outreach activities and educational activities such as this one in order to raise awareness of children's environmental health among clinicians and other health professionals and the community at large. And so every PESHU team is different, and at our PESHU at Mount Sinai, our core team is, I'm the fellow. We have multiple environmental pediatricians. We have a PESHU coordinator, a social worker, and industrial hygienist. But the great thing about the PESHU is we have access to a whole network of professionals in other fields like emergency medicine, toxicology, ACMED, et cetera. And I think Jerry showed this morning, but just to review, the PESHU regions correspond to the EPA regions. So we're EPA in EPA Region 2, and we cover New York, New Jersey, Puerto Rico, and Virgin Islands. Though I'm kind of sad that as a fellow I have not been assigned to Puerto Rico or Virgin Islands case yet. So maybe before I finish my training. So as Jerry mentioned this morning, the PESHU clinical consult team, we deal with a whole variety of environmental exposures, from the more traditional environmental exposures like lead and mercury to the more what we call emerging toxins of concern like BPA, phthalates, and other endocrine disrupting compounds. From a Region 2 perspective with regards to schools, so I just started my fellowship about a year and a half ago, and just in that year and a half, I've gotten many consults regarding school environmental health. Most of these consults come either from individual parents or actually PTA groups. And the most common school environmental health issues that I deal with have to do with air quality. And that's probably, from a clinical perspective, the most important one that should be addressed to improve children's health, I guess, the most. The other common calls we get in Region 2 about schools have to do with construction and renovation, because New York City, we have over 1,000 public school buildings. They're all quite old, and they're in a constant state of renovation and repair, so we get many calls about that, and Maida is actually going to discuss one in more detail because it highlights some nice principles in children's environmental health. We also get questions about things like PCBs. You might have heard there was an issue with PCBs and the lighting and the caulking in the New York City public schools. We still get calls about asbestos when parents get sent a letter home saying asbestos was found in a certain area of school and it's been sealed off and is being remediated. parents understandably are concerned. Is there a possible exposure? What does this mean for my child? And so that's where the PESHU comes in to try to answer that question for them. We also get questions about school siting, the location of schools, and the proximity to potentially toxic sources. And then also one of our attendings at the PESHU is an expert in artificial turf. So some schools have been contacting us about what are the possible risks of installing artificial turf. So that's kind of an overview of some of the issues we deal with, but it's not comprehensive. I'm just hitting the highlights. Okay, so we're going to begin our talk with an overview of basic concepts of children's environmental health. And I'm just curious, how many of you in the audience are trained in nursing, physician assistant, physician in the medical field? Okay, so a good number. And of you that raised your hand, when you think back to your core training, so nursing school, medical school, how many of you received education in environmental health? Okay, maybe one. And did you find that education adequate to address the things you're seeing now in practice?
I received mine as part of my MPH.
Oh, I see. Okay. So that's kind of what the experience is when we talk to healthcare providers. And my own experience just going through medical training, I was quite critical, being extremely interested in environmental health my whole career. I was looking for it. I'm like, when are we going to start talking about this? This is important. And it came up, maybe you talked a little bit about asthma, lead's always mentioned, asbestos is usually mentioned, but not in a comprehensive way and not in a way that I feel is useful for nurses and doctors to integrate into their practice. So I think some of these basic concepts are really important, so I'd like to review them. And Jerry did a wonderful job going over these this morning, so this is kind of like a pop quiz to see who is listening, or if your coffee didn't kick in yet, maybe you're going to hear this for the first time. So here we have a child and an adult in an environment, general environment. And environmental health is about everyone, but it's especially about children. So thinking back to what you heard from Jerry this morning or what you know from your own work, can you think of some ways that children would be more vulnerable to toxins than adults? Can anybody yell out an answer?
They're lower to the ground.
Lower to the ground. And so what does that mean in terms of exposure?
They're more likely to breathe in stuff and touch stuff.
Exactly. So breathe in things that are close to the ground, touch things that are on the ground, put things in their mouth from the ground. Good.
A lot of these toxic chemicals that get airborne are heavier, so they concentrate lower, close to the ground, so kids are breathing in.
Very good. So a lot of toxins are heavier than air and could accumulate nearer to the ground, so nearer to a child's breathing zone. What else do you remember from this morning?
Kids are growing very quickly neurodevelopmentally, and so the windows of opportunity for exposure and harm are greater than an adult.
Exactly. So children are developing rapidly. There's different periods of susceptibility. Also, they ingest more food and water per unit body weight. Recall a few speakers mentioned they breathe in more air per unit body weight, have a higher surface area to body mass ratio. And then in the younger kids, they have a lower variety of foods as well. So good. Those are pretty much the general principles which I felt weren't taught to me officially during medical training, but are very important to take into account when considering how the environment affects kids, how the school environment affects kids specifically. Another term that you might come across when working in environmental health issues in your school or your organization, you might have heard route of exposure. Do you know what that is?
Say that again.
The route of exposure. So that's basically how a toxin, I'm using the word toxin very generally here, could get into the body. And could somebody tell me some of the roots of exposure you think about when you're thinking about an environment that a child is in? Great. So we have... Sure, we'll go with electromagnetic. So the big ones we worry about, especially in the little kids, are oral ingestion, so ingesting a lead paint chip, contaminated dust, inhalation, dermal exposure, something getting on the skin. And then the other one is actually transplacentally. So for a child before they're even born has the potential to be exposed to environmental toxicants that mom is exposed to. So another principle to keep in mind is once a child absorbs a toxin in their body, the toxin has to go somewhere. And so another kind of principle to keep in the back of your mind when you're focusing on a class of toxins is where it goes in the body and how the body processes it or metabolizes it and excretes it. So for example, something like lead. Does anyone know where lead gets distributed in the body? If a child eats a lead paint chip, where it goes? Bones, exactly. And the thing with kids is kids have a different body composition, fat versus water content. They're growing, so the bones have higher turnover. So just, we're not going to go through all the details. I mean, that could be a whole course in and of itself. But these are just kind of general things to keep in mind when you're considering something that a child may be exposed to. And then this is extremely important, and it was mentioned several times before. Something called target organ susceptibility, meaning children, as was mentioned a few moments ago, they're developing quite rapidly, and they also have more years ahead of them to accumulate toxic insults. And so when you think about a child exposed, lead is the classic one, lead tends to target the nervous system. And so a child's brain development starts occurring in utero and expands actually through adolescence, actually till early 20s. And so if you think about the nervous system, all those neurons, they're connecting, they're branching out, and that's how the nervous system's formed. And so an insult early on could affect how the nervous system is forming. So that's just a general principle to keep in mind. And not only the nervous system, but if you think about the lungs, the alveoli, the part of the lungs that exchange the oxygen, they start growing in utero, and through age 8 really is when the lungs are, almost fully mature. And so insults like secondhand smoke early on along the way could affect that normal development. So given all these unique susceptibilities to environmental toxins, it's important and I guess quite sad and disturbing to note that most chemicals to which children are exposed to have not been tested for toxicity. Okay, so now we're going to play a guessing game. Can anyone guess how many chemicals are in industrial use in the United States today? Oh, you guys are... Okay. Yes. Yes, 85,000. And how many do you think have had basic toxicity testing done and are considered to be safe? You guys are good. Okay. Yeah. So roughly 80,000 chemicals, about 3,000 of them are called high production volume, meaning over 1 million pounds a year. The EPA did a recent review about the chemicals in commerce and what types of studies were done, and really found that most chemicals have not had adequate testing. So basically, there's international authorities agree that there's 6 very basic tests that a chemical needs to go through to determine toxicity. It's like acute toxicity, chronic, developmental, mutagenicity, ecotoxicity, and environmental phase. So 6 tests. And what I find surprising is 93% of the high production volume chemicals are missing at least one of these basic tests. 43% lack all of those tests. 43%. So that, to me, that's surprising. Only 7% of those high production chemicals have all 6 of these are just the basic toxicity tests, and only 20% have any information available on developmental toxicity. So to me, this represents a significant gap in chemicals regulation in the United States, and our current policy framework for that, called TSCA, Toxic Substance Control Act, is, in my opinion, in need of a big overhaul to better protect public health. But that's for another lecture. Oops. Okay. So kind of setting the stage is we know that there's a lot of chemicals used in the environment, and now there's evidence that we are exposed to chemicals. So has anybody ever heard of the CDC's National Exposure Report? Yeah, I see some. That's great. So for those of you that don't know, the CDC tracks exposures to many environmental chemicals via something called biomonitoring. And that term, for those of you who are unfamiliar, just means the direct assessment of people's exposure to chemicals by measuring the chemicals or their metabolites, their breakdown products, in typically blood or urine, although there's tests that look at other things like hair. So a common biomonitoring one is a blood lead level, or a urine mercury test. So for this report specifically, the CDC used this is a very in the know audience, so NHANES, you guys know NHANES, the National Health and Nutrition Examination Survey. So they use that, which is an ongoing study of the civilian U.S. population from age 6 to 85. So they use NHANES and the samples from NHANES to look at now 212 chemicals, including metals, pesticides, VOCs, tobacco, plastics, flame retardants, etc. And so this information basically provides the geometric mean and range of of all those substances in the U.S. population, broken down by age group. And really the purpose of it is to guide research and public health decision making. It's really not useful on an individual clinical level because we don't know what a lot of these things, what these levels mean on an individual basis, but it's just to kind of give trends of what our population is exposed to. And one of those trends as a pediatrician that I find troubling is that if you look at, this is phthalates. You guys have all heard of phthalates? So phthalates are one of those emerging chemicals of concerns. They're plasticizers. They're used to put flexibility into products or to hold color and fragrances in personal care products. And so in this National Exposures Report, they looked at phthalate levels in urine, and all these are the different metabolites of phthalates, and if, as you could see, for each of the metabolites in general, children have higher levels in their urine than adolescents who have higher levels than adults 20 plus. So children tend to be exposed more. And as mentioned in a previous talk, so not only considering children, but really exposures across the lifespan, starting even before a mother gets pregnant, but during pregnancy, through infancy, childhood, adolescence, and adulthood, it's important to understand the implications of the wide range of exposures at different life stages and the cumulative impacts of these exposures, again, through adulthood. And so in the, I guess, world of pediatric environmental health, so another really important concept to understand is well, actually, it's kind of two concepts in one. One is how the social determinants of health interact with environmental exposures to impact children's health. And then also whether certain groups of children are disproportionately exposed to environmental contaminants society. In this picture, it's from the EPA website, and as you can see, it's a playground of a school with a beautiful factory and a smokestack in the background right next to the playground where kids are running outside, breathing at a higher rate, playing in the dirt. And the concept of environmental justice can also be applied to schools. And basically, when considering environmental justice issues with schools, you could think of kind of three big key concepts. One is school siting, when a school is sited on or near a hazardous location, and whether this is happening more in certain communities than others. And Maida is actually going to give an example of that that we saw in our PESU. School funding, so the capacity to mitigate or maintain a healthy environment for children at an existing school. And we really see disparities in New York. It's a geographically small area, but a very, very diverse area in terms of socioeconomic status and race. And for example, we were contacted by a PTA to assist. They had some environmental health concerns at their school, and their PTA has an annual budget of $1 million. And then we have other schools that we've worked with who kind of have a PTA with really very limited budget and just within a few miles of each other in the city. To highlight the point that neighborhood makes a difference. Certain populations have higher exposure to various environmental hazards, not only at school, but at home and in the community. So this is a lead poisoning map of New York. I don't know if any of you are familiar with New York, but it probably won't be surprising for you to realize that the rates with highest levels of lead poisoning are in areas that are of lower socioeconomic status. The same thing with poor housing and asthma. The left map is areas that have, or the percentage of residents who report fair to poor housing conditions. And so the dark red indicates a higher percentage. And then the map on the right is asthma hospitalizations in New York City per 1,000 children. And again, the darker red is a higher rate. And again, it may not surprise you that a lot of the neighborhoods with the highest rates of both poor housing and asthma hospitalizations are some of the poorer neighborhoods in New York. So kind of putting it into context, neighborhood matters, the social environment matters, school matters, home matters, and environmental health encompasses a lot. But given all that we just discussed, it may be easy for us as healthcare workers or parents to worry because a kid could be constantly seen as vulnerable in their homes, schools, and communities. So feel like we need to isolate them all in a bubble to protect them from human and natural toxicants. But I'd like to argue that that's not really a useful perspective, and to kind of keep in mind as we think about all this going forward, that there's really a benefit of positive and participatory action rather than a fearful reaction. And so as pediatricians, the healthiest children we see are those that have nurturing, stable home environments, are not living in poverty, have appropriate nutrition, go to good schools, are exposed to appropriate language and social interactions, have strong family connections, social connections in the community, etc. So with that in mind and keeping all those general principles, I'd like to turn it over to my colleague Maida to discuss some interesting case studies that we've seen. Thanks.
Thank you, Lauren. Good morning, everyone. It's great to be here. This is a beautiful space, a wonderful learning environment, and I've anecdotally found that whenever we talk to audiences on the topic of school, they happen to be the best audiences. And we've seen this from the discussions today, is that I think that we have a lot to learn from all of you in the audience, so it's been great to hear your comments. I'm going to walk through some cases that sort of highlight some of the principles that have been raised this morning. And so can anybody guess what this building is? It was not temporary. It was a school facility. It was actually a daycare. Anybody know this daycare? Kitty College in Franklinville, New Jersey. Okay. And what was it prior to?
Produced mercury thermometers.
Correct. Yes. So this is the case of a New Jersey daycare that formerly housed a mercury thermometer manufacturing company. And it was closed when air and surface testing revealed elevated mercury levels. And it operated beginning in 2004. And there are about 162 children in the program ages 8 months to 13 years because they did have an after-school component. And so, whenever you hear stories like this, you're sort of like, how did that happen? How did these events unfold? And in any event like this, it takes actually a cascade of events for this to happen. So I'm going to walk you through exactly what happened. So the mercury thermometer manufacturer opened in 1984. The plant closed 10 years later, and in 1996, an EPA report cites there was no immediate human threat. And when they said that, what they meant was to any external areas beyond the site. It was deemed ineligible for federal cleanup, and then it was sold without a hazardous waste cleanup in 2001. It was then rezoned, granted a new certificate of occupancy. It was renovated and granted a license for a daycare, which then opened in 2004. The Department of Environmental Protection was then conducting site inspections of sites that were identified as low priority contamination sites. They drove up to the parking lot and saw that it had been turned into a daycare. And that's when they wrote a letter to the owners of the daycare saying, we'd like you to do some indoor air sampling for mercury. And those first series of tests came back positive for mercury. And then EPA went in and repeated the tests. When the tests were repeated, the daycare was permanently closed in 2006. And so you can see how difficult it is actually to get through that process, yet somehow this school made it through all the way. So elemental mercury. Anybody here in the audience play with elemental mercury as a child? Quicksilver? Yes. So anybody have symptoms from the mercury exposure? No. So it's a pretty common thing, actually. So this is one of the things that highlights children's unique vulnerabilities, right? Quicksilver is metallic mercury. I don't have a picture of the beadlets, but you remember those beadlets is very attractive to kids. You want to push it, you want to play it, you want to roll it around on the floor. That's why children are uniquely vulnerable. The other thing is that mercury vapor is heavier than air, so the breathing zones of children is more likely to expose them to higher levels of exposure compared to adults who are walking in the very same room. So if you think about children too, they like to carry things with them, their toys, their backpacks, their blankets, their teddy bears, and what do they do with those things? They drag them on the floor where the mercury beadlets may be located. And so we did see in this case where one child actually had a blanket that had elevated levels of mercury, and that child had persistently elevated levels beyond the period that was typical for this particular population. So it is a vapor at room temperature. Inhalation is a major source of exposure. Urine testing is typically the testing that's recommended specifically for metallic mercury. And the health effects are called acrodynia or Pink's disease. And this is a disease that we don't really see that much anymore. And it was seen more commonly in the early 1900s when teething powder actually had mercury in it. And it was when you saw the hands, how many people were exposed and how many people actually had effects, we still don't really understand why certain people have the symptoms and certain people don't. So something like 1 in 500 exposed have the effects. And it points to sort of what Lauren was saying, is that there are positive behaviors that can counteract the negative impacts of environmental exposures, like a healthy diet, a good education, a loving, supportive family, and so forth. So here's a picture of acrodynia or Pink's disease. And if anybody in the audience knows Kawasaki's disease, it's an autoimmune disease. A pearl that one of my former mentors shared with me was, if you're thinking about atypical Kawasaki's, you should think about mercury exposure. And so you see this really painful red rash on the hands and the feet. And you can also have other associated symptoms like changes in behavior, a fine tremor, painful neuralgias. the change in behavior, specifically an increased shyness. And so we did actually see a family at our PESU with a clustering of these types of symptoms, not related to Kitty College, but related to having had a vial of metallic mercury that the family had stored in the basement that the preteen sons had actually found and played with and hadn't told anybody about for a period of about a month. And that is the only case that of acrodynia or Pink's disease that we had seen. So we actually had to scour the country and sort of find people who had actually seen acrodynia or Pink's disease in the past, because it's really uncommon to see today. So we were part of an investigative team. This was very much so a collaborative process. We worked with the New Jersey Department of Health, the Centers for Disease Control, the Agency for Toxic Substances and Disease Registry, the Environmental Protection Agency, and our PESU. And so environmental testing was performed by the EPA. They also went into the homes of former staff and students who volunteered to have their homes tested. And we don't often recommend environmental testing in terms of biomonitoring, blood or urine testing for populations that are exposed because of limitations in testing, depending on the source of exposure or the exposure of concern. But in this case, there is a very clear test that is reliable, that can tell you potential risk related to health effects. And so this is one of the rare scenarios where we actually did recommend that urine be collected on the children. And so they conducted a mercury screening in the children and staff, and they initially targeted the screening to the children that were present within 60 days of the closing, consistent with the half-life of mercury. So we thought they would target the testing on the population you're most likely to see positive results on. And then the children who had what was considered elevated urine mercury levels, which is greater than 5 micrograms per gram of creatinine, those kids were retested monthly. They also sent in a Centers for Disease Control Epidemic Intelligence Service officer to conduct a chart review of medical charts of the students who had attended the school to look for symptoms of acrodynia or Pink's disease. And so this shows you the results from the urine testing. And so in August of 2006, 72 children were tested, and they had a mean that was less than 5. This is still higher than what's typically seen in the US population. And then they repeated the children who had levels greater than 5 and saw a slight decline. And then a second repeat for the children who were persistently elevated. And then they decided later in December that they were just going to offer the testing to anybody who wanted it. Because you can imagine if your family, if you had a child that went to the school, you would want sort of that test just for reassurance. And that number was very reassuring. And so this is a graph, and it shows you the days since the last exposure at Kitty College. So the time the child was last at Kitty College up to 200 days out, and the urine mercury levels and what happened over time. And so what it shows you is that the farther away you got from the closure of the school, there was a very nice decline in the urine mercury levels. And so what they found was that children attending the daycare within 2 weeks of the urine testing had significantly higher levels than children who were at the daycare greater than 2 weeks from the closure. So over 20 times higher for the kids who were tested within 2 weeks. And so our role as a PEDS environmental health specialty unit is really in the messaging to families. And so we were involved working with the Department of Health on their fact sheets, for example. We attended community meetings. We had periodic updates with the entire investigative team. The Department of Health was very transparent in their communications in this case, and they updated their website with communication weekly, which is very important for families to feel like they have ready access to information and don't feel like anything's being withheld from. About 68 calls related to Kitty College, and that very quickly overwhelms our PESI resources. It's very tough to tackle a community level exposure like this, and I think we've already touched on that earlier today, sort of the lack of resources in terms of assistance to schools. And so So you'll see that here these lines are community meetings. This is the first community meeting, this is the second community meeting, and here's the third. And you can see that sort of there were blips in our calls, and why was that? So the first blip was after the fact sheet was distributed to the community and urine testing was offered, and so families called us and said, should I pursue this urine testing? The second blip was after the urine test results were received, and they wanted guidance on what those results meant for their child. Just to go back a slide, my colleague Nathan Graber actually went to the third community meeting that was here, and we really think that those in-person meetings are incredibly helpful in addressing families' concerns. So this is our message, and it's really important in scenarios like this that messaging is consistent across the various groups, because it's very anxiety-inducing when families hear one thing from one agency and another thing from a different agency. So that's why we think this is a really great example of coordinated risk communication. So one, the most important message was removal from the ongoing source of mercury exposure was the most important clinical intervention. Urine testing was recommended, and typically you start to see effects on the kidney at 20 micrograms per gram of creatinine, and you can see the more acute symptoms at 50 micrograms per gram of creatinine. And none of the children were at these levels, thankfully. So the results were very reassuring. There's limited evidence on long-term effects from low-level exposures. This is a gap in children's environmental health. There's still a lot for us to learn about what chronic low-level exposures mean, particularly for children with special needs, and that consultations with specialists was warranted as indicated. And so to conclude, urine mercury tests indicate that children were exposed, though the levels did decline with time away from the daycare, and that coordinated response is critical with regards to messages to the community. What was nice about this case is that very rapidly they passed legislation saying that you cannot cite schools in areas without considering its historical use. So New Jersey was really one of the first in the country to put forward this type of legislation. And so it now requires the evaluation assessment of the interior of buildings to be used for daycares or education. It actually puts the onus on the Department of Health to establish maximum contaminant levels for building interiors that are protective of public health and safety. That's a large task and very difficult to implement. Construction permits would not be issued if the contaminant standards were not met, and a no further action letter is required from the Department of Environmental Protection prior to issuance of a certificate of occupancy. And so this is really groundbreaking, and we've since learned from Kitty College that schools have been cited in places like former funeral parlors, former gas stations, and so I have a couple of other cases that I'll shortly walk you through citing issues like that. So we're at a school talk, so these are not surprises. What is this building? It's a school. That's right. Would anybody have guessed that if we weren't here today talking about a school? No. So this is a school in the Bronx. And anybody guess what it was formerly? It was a former factory. It was a former car garage auto mechanic. And before that, it was a lamp manufacturer. So here's the school, if anybody's familiar with the Bronx. I actually trained not too far away from here, and Lauren as well. And so here's Jerome Avenue and the 4 and the 6 train. And this is the school. It is actually a pretty industrial area in this particular pocket of the neighborhood. And here's the front door of the school. And so in New York City, actually, the School Construction Authority voluntarily tests schools for indoor air quality, and they consider historical use when renewing the lease on any property. So this is a voluntary action on the part of the School Construction Authority. And what they found when they learned of this history is that this school had high indoor air levels of a chemical called trichloroethylene. And TCE is a metal degreaser, which can be used in both of those industries. And so one of the first things we do, this is a very complicated slide, and you don't need to sort of know this in detail, but sort of one of the first things that we do as a PESU is try to put those exposures into context for families. So what we do, we sort of say, these are the guidelines for occupational exposures, these are the levels that have been seen in other cases and perhaps other schools if that information is available, just so families can understand sort of what these levels mean with respect to any comparable exposure scenarios. And so this is really what we do, is sort of the crafting those messages. And we found that it's so important to craft clear, concise, lay-friendly languages. And sort of our framework is based on the Center for Risk Communications message map. And this is Vincent Cavello's work and Richard Peters. And so our 3 key messages are typically focused on these 3 areas: define the exposure, explain what's known about the potential health effects, and then leave families with action items. So what can they do to prevent and reduce exposures? And so this is what that message map framework looks like. So the topic could be trichloroethylene, what is TCE, what are the health effects, and what can families do about it? And so here's our simple message map. These are always works in progress. They're really actually, once you sit down and try to write one, you can see how challenging it is to actually write lay-friendly language and to keep it concise. And so sometimes I'll take a look at something we developed 6 months ago and I say, gosh, we really need to keep working on this. But this is one that we used for this particular scenario, and it shows you, let's go down the health effects. So children can be exposed by breathing it in the air, but the total amount of exposure is not really known on an individual to individual student basis. Breathing high levels is usually associated with irritant type effects, headaches, dizziness, why do I keep on doing that? Sorry. Ear, nose, and throat irritation. Long-term exposure can affect the liver, heart, kidneys, and central nervous system. And then short-term effects are usually improved with removal of the exposure in a matter of hours to days. And there's still a lot we don't know about long-term effects in children. The most important treatment is removal from the source of the exposure, and ventilation is the most important intervention. In this case, school closure was the most important intervention. And that we did not, in this case, recommend urine or blood testing because it would not change our clinical management, and those levels would not tell us important information about potential health effects because those clinical reference guidelines do not exist for this particular exposure. We were present at the community meeting where the chancellor actually spoke. So it shows you how high level this was, that the school chancellor for New York City schools actually came and was the key messenger for that particular event. And his 3 key messages were, I'm sorry. This should never have happened, and we are taking steps to make sure this does not happen again. And he said it again and again throughout the evening. And we think that these types of community meetings are really important, even though they can be very challenging as a public health person, the pediatrician, whoever it is. But it's a really important opportunity for families to voice their concerns and their frustrations. And so one overlooked health effect, and the one that we think is one of the most important in scenarios like this, is stress. And so this is one of the important ways to address the stress the families are feeling, but it is something that we think deserves more attention. So a couple of other cases that we've been involved in. This is a school in Brooklyn, New York that had water intrusion problems and was going through some remediation. But unfortunately, that work was disruptive of the school day. They were also doing things like tarring the roof, for example, and they were also generating a number of dust hazards inside the school. So the students would walk into the school and there would be dust covering their desk. And sometimes those students were involved in the cleanup of the dust. And so you can see that there's some really basic things that shouldn't have been happening. And in this case, it happened to be a school with a very active, engaged, and organized parent-teacher association. And so they were really effective, actually, in working with the school to modify the timeline of the project and to work with them to really minimize the dust hazards that were being generated during the school year. So we think of this as a really good example in terms of preventing and reducing exposures during construction and renovation. And what's nice about this particular school is that active and engaged parent organization is now working to help other schools in the city who are faced with the same issues and who may not have the same types of resources available to them. And in that school, again, it was very stressful. The parents were really upset about what they were seeing as they dropped their kids off at school. There were a number of very heated and angry community meetings, many of which students were attending. Actually, they'd be sitting in the back of the room with their parents. And so the students actually absorb all of this. They hear what's going on, and hearing that their school may be a toxic environment is a very troubling message to children. And so that's one of the things we actually talk to families about, is sort of to really think about how you are talking about the issues that were going on with their children, because that stress can be pervasive. And so Cappy Collins, who's one of our former fellows in environmental pediatrics, crafted this message map. It's a very simplified version of a message map specifically for the children. And it says, every school building needs regular maintenance to keep the school safe for the people inside. But work on the building can create a lot of dust. And while the work is going on, it's important to stay healthy by washing dust off your hands, especially before you eat and after you've been playing outside. So this is a really basic message. It applies to any school. And it sort of takes away the negative messaging that the children were hearing a lot of and puts it in a positive framework. And so it gave sort of parents and teachers sort of the tools that they could use to discuss this in a hopefully a healthy way with the students. And this is the last case that I'm going to talk about. This is one that Lauren Zajac played a really critical role in. And this is a school on the Upper West Side of New York. And so the school is right here. And literally this far away, they're planning a construction site right adjacent to it. It's the entryway to the school and a sidewalk, and then the next site will be a new facility, which you see here. And so the parents are very concerned that this close proximity of construction renovation, which is a really common thing in New York City, right? This happens all the time. It happens here in DC. We build wherever we can build. And so the question is, if this does proceed, how do you minimize any potential harms to the children? And really one of the top ones is noise, right? How do you minimize the distraction of jackhammers outside of a school day in and day out? So Lauren and actually a pediatric resident who was on elective with us did a really wonderful job sort of cataloging the potential risks of construction-related hazards, not at the school, but at a nearby site. And we hope that that will lead to some mitigation of those effects if this project moves forward. So just to summarize, with respect to children's environmental health, special knowledge of kids' unique vulnerability is really important. And keep in mind sort of the risk communication theory. And one of the things is when you're messaging to families is to acknowledge there's a lot of mental noise going on. They are really stressed because when you hear about these cases like the TCE case, it's really hard for families to understand what that means, what is TCE, and what that means for their children's health. And so we've found that it's really helpful to craft messages in advance, keep them short and simple, and that often pediatric providers, including nursing and allied health professionals, are often helpful to have as risk communicators because of the level of trust that they may be perceived as having. So these are some of the messages that we've, the lessons that we've learned. Communicate early and often with families. Transparency is key. Keep a timeline of events. That's really helpful for families in advance, and to try to anticipate questions rather than being reactive. So oftentimes the media gets ahead of sort of the whatever agency is the front line in messaging. So if you can anticipate those concerns, it's super helpful for families. Keep messages consistent, and then to debrief after these types of community level exposures. And so now I'm going to turn it back to Lauren, who's going to walk through some key resources. Sure.
I think we only have a few more minutes. So basically, the handout, you have it on your flash drive, and we put together a list with the links to all of the resources that we find useful. So I would encourage you to look at that, and then we'll spend the next few minutes doing questions.
About just the construction exposure either in the school or near the school, were there not any federal, state, or local laws, regulations, guidelines that, for exposure of school children in the buildings?
There's some, and they're piecemeal. Like in New York City, they have a noise ordinance that dictates construction projects and how much noise they could generate and what type of mitigation devices should be used to keep noise levels below a certain threshold. But really for construction, not too much.
I agree. There are sort of exposure-specific guidance and regulatory levels that are allowed. I think enforcement of that is the challenge. And so, in the case that I described in the Brooklyn school, it was the parents who were really making sure that those regulations were being enforced. And oftentimes that's what it takes, unfortunately. Yeah.
Can I ask a question as medical providers? I have friends in Philadelphia who are pediatricians, and I talk to them a lot about this as I do work in schools. And I'm wondering, when we see these kinds of conditions, I've asked them what they do and what they should do, and they always express confusion about them being able to interact at all with that, either with the parents or the patients, the children that come to their offices. And I think all of us are looking for help when we see a condition. Can the medical community help tell us, what do we need to do? Do we need to close that area down? Do we need to remove people? Do we need to let them stay there for a day, a week, a month, a year? From the medical perspective, we need, I think, some help in trying to understand the nature of the risk in that practical way. Can you offer something,
Sure.
You see this?
Yeah, no, that's a great question. And I think that really the origin of the Pediatric Environmental Health Specialty Unit is to provide that type of technical assistance to healthcare providers, communities, and public health officials and others to specifically address those questions. And so we are a resource, and there is Jerry Paulson in the Region 3 PESU has a colleague who works out of the Children's Hospital of Pennsylvania to specifically address environmental health concerns. So there are contacts, and we are regional resources, but we work beyond our region as well. I think everybody sort of gets questions from everywhere, and it is a network. And as Jerry mentioned, each of the PESUs have specific regional expertise. So if a particular topic is not in our particular area, we will reach out to others within the region to find that assistance. But I think even beyond that, I think there are a number, the regional EPA offices have leads on schools. Many of them do, not all of them. And so I think that you can go to the PESU as a first contact, and the PESU can help refer you to sort of the local resources that are available. But I think folks here in the audience may know of other resources that I personally heard of some resources this morning that I was not aware of. So I agree. I think it's a matter of us knowing the algorithm of who to go to for what particular problem. And it's actually difficult to figure out, as Lauren has tried to do that for us in New York City.
Oh, hi. Thanks for reminding us of the large number of industrial chemicals that are out there and how few of them are actually tested. I want to also highlight another source of chemicals, and it's in food. So there are roughly 9,000 chemicals allowed in food. Less than half of those that are on purpose put as food additives have been fed to a rat. Not even think about those that were tested for developmental toxicity or reproductive toxicity. So I just want to keep everybody keep thinking about food as a source of chemical exposures. and especially in school foods. Not just the choices that we can make at home, but those foods that are part of, for some kids, is in many cases the only meal they get. So how to make sure that there is not only awareness, but what can be done to prevent or minimize exposure to chemicals that not only the BPA type chemicals that are not put on purpose on food, but especially those that are used and put on purpose on food for some particular function.
Yes, thank you for that point. I think that is a big issue, and we find with a number of environmental exposures that foods actually can be the major source of exposure, particularly processed foods. But there is also the issue of contaminants and food additives, that are generally recognized as safe, right? Sort of that kind of big category that hasn't really been studied for human health impacts. But I actually know that Pew here has done some work in this area in their food chemical. Is that you? Yes. Thank you for your good work.
This question is a segue in a way, even though it wasn't intended to be, but I noticed on that one slide on the Mercury business, you said, oh, this is a complicated slide, you don't need to pay that much attention, but I was looking at all the different levels. Go back to that one. On the right-hand side, you have, Cal EPA, you have ATSDR, so you have maximum levels, residue levels, I guess that's what that means. And they're all dictated maximum levels that are determined by different agencies for different reasons. And so to the gentleman's question about how can we help in the medical community, and then the thing about tolerance levels, whether it be in food or water or what have you, here's where science and politics is on a crash course, because we can't know all this stuff. All of these things, first of all, are complicated to know, and the pieces can be very helpful in helping us navigate that, because for the average, mortal to try to answer that question during, a 24-hour time span is almost impossible. But also that the politics are not coordinated, I should say. What FDA is allowing in foods versus what EPA allows in tolerances, things like that. So I'm just pointing that out, that this is an area where it's no wonder we're confused, and if any help can be brought to bear on those things, knowing that in advance. Because developing these messages that the lay public can understand, you're sort of struck dumb by your inability to make that work. So just saying, that would be a helpful resource to somehow bring these things together in a way that the rest of us can use quickly.
Thank you for that comment.
And I would say that that's probably one of the most powerful things in the stories that you're. One of the most powerful things I see in the case studies that you presented there is, especially in the first one, was the necessity to sort of create, to harmonize between all of these different organizations and agencies who are a part of this first, to get them together, and then to develop the messaging that is meaningful sort of across those agencies for that particular case. And we want to find, we want to be able to take the cases and sort of generalize it and make it easier and take it to the national level. But the fact of the matter is, it is community by community and case by case. But I think the thing that does run through it is the model that you're talking about, having the right people, all of the right people who are involved in that particular case, speaking to one another, making this meaningful for that case, and then harmonizing the message that's going to put citizens and community into right action and empower them in that way, so that the medical professional that Jerry was talking about who's dealing with that kid has a conduit in which to be in conversation, positive, meaningful conversation with the school and with the EPA and with the state health department, so that it's not, if people are not at odds and you're not giving a message that says pull the kid or shut it down, that people aren't going to be able to do, but that you can get together and harmonize around a message and an action that people are going to collectively be able to take that has meaning for them.
Agreed. Yes, thank you.
Hi, I think everybody in this room is on board with everything that we're learning, but do you have any suggestions on how to get other people back at school districts, especially when the school budgets are, almost nothing, and the bottom line is always the most important, and what food costs and what chemicals are used. Any ideas on how to motivate, kind of get through some of the bureaucracy?
Yeah, that's a good question. I think sort of where we've seen success is really with the grassroots efforts of either parents or teachers or school staff. One story I didn't share was a school that brought us in specifically to do a walkthrough of the school to assess their school environment. And in that case, there was a parent champion who was able to pull together a greening committee that included the school administration, faculty, the superintendent staff, the janitorial staff. And what our industrial hygienists did in that case was they taught them how to do the school walkthrough. And then they developed a mechanism for saying, well, if we're going to be purchases, how do we choose the healthiest products for kids? So you kind of need that investment from the diverse groups involved in the schools, I think, to have success. But I think some of the policy changes are equally important that we've heard about today. And then we need more resources for the schools. So we have a lot of sort of guidelines for schools, but they tend to be guidelines that are this thick, right? And it's just overwhelming for anybody to sort of tackle. So we need the technical assistance for the schools to sort of get through those very, very technical documents. And then we need funding opportunities. We heard about sort of the struggles to assess the impacts of these green schools, and we need really targeted funding opportunities to assess the human health impacts and the benefits of schools. So it's pretty comprehensive, but I think you're right. And I think it can happen. I think sort of it's just a matter of finding who that champion is in the school, and it could be actually the school health professionals. So I think there are a number of folks you can look to locally for assistance.